Yeah.
Yeah. Okay. Hey, Vijaya, please start the recording.
Yeah, it is being recorded.
Okay, great. Thank you. Um, Let me just say, okay, and let me just get this thing on. So, welcome, friends. This is um, Dr. Amit Chakravarti. Um, I'm the president of API for the few more days, actually. So, it is a great pleasure that the last CME of the whole year we have done. Actually, we have given a record hours of CME. We have done almost 60 or 62 CMEs for the whole year, which includes the trips, of course. And we've got 10 CMEs at the convention coming up. So thank you very much for your support all the year, all throughout the year. The CME topics have been excellent. Thanks to Tarak. He's been very diligent. I couldn't have found a better colleague and better person who to head the CME forum. He is actually right in my neck of the woods. He also is a psychiatrist, professor of psychiatry at UAB Huntsville. And so today we have got I mean, it's nothing can be better by finishing the thing with a urology seminar because I'm a urologist, and these two people are extremely busy people. Nimesh, I knew him as a medical student because his dad also is a urologist, and I see him grow up into a great urologist himself, and his father must is a I'm sure he's on listening to you, buddy. And Aditya, extremely busy. He was the president of the Indian American Urological Association, and recently did a lot of work there. Great guy. Here, so they have got excellent topics, which they will introduce themselves. Especially, I'll introduce Aditya. I think you're going first. I think so. Aditya Bagrodia is a professor of urology and radiation oncology, disease team co-leader of genitourinary oncology at UC San Diego Health. So he's got a great big bio, and that is. We'll take the whole hour if I go through that. But I just wanted to have him get started with this conference. I will be the moderator, but we will ask you to just post your questions in the chat box, and after Aditya is done, I'm going to ask those questions to him, and maybe put a few comments myself. um, don't get to do that too many times because this is a urology topic. I can do that, and then Aditya can introduce Nimesh, and then we can finish the conference. And again, thank you so much for all your support this year. And one last shout out for all of you guys to please come to the convention. Please visit the convention website. It is apiconvention.org, and you'll know that we've got great program, great CME, great Women's Forum. We've got a lot of celebrities, including Nita Ambani, who's coming for our to get the API Humanitarian Award. We've got a lot of other celebrities, film stars, tennis players, etc. We've got great entertainment. Again, Nimesh Patel, stand-up comic, Kumar Shanu, and Vishal Shekhar. So it's going to be a very fun-packed 3 days. It's going to be on July 4th weekend. So registrations are still open, though we have closed a few categories. But please try to join. Over to you, Aditya.
Okay. While Aditya is doing that, I would just like to say that you will get your CME credit within a week after you will get the email with the same email that you have registered, and please fill out the evaluation, and then it will come from the EMED events. It won't come from the API. The evaluation will come from the EMED events. And probably by next Sunday or so, you should get it, fill it out, and then you will get the CME right away. And I really appreciate personally Aditya and Nirmish for joining on the Father's Day. They both knew it. They both had talked about it on our email chain, and still they're here. And happy Father's Day to all, and even the moms who are like fathers nowadays. So
And that's what one thing I wanted to also tell you that thank you so much for all joining on Father's Day. And if you notice, I've got a T-shirt which says "Grandfather." So it's like a
Oh,
godfather
yeah, I can
teacher.
see it. You have to get
Yeah.
up on it
Yeah,
probably.
I'm gonna get up, and that is called grandfather right here. So I'm it's like Godfather. So I'm going over to the thing, but I'll be muted and listening to all of you. Thank you so much.
Perfect, perfect. Thank you. And it's an honor to be here. I've been involved with the Indian American Urology Association. That's how I got to know Amit. And it's really a treat to kind of stay engaged with the community. And Amit's absolutely kind of an expert in prostate cancer screening. So I will kick off. And my children actually surprised me with tickets to a play. So I probably need to hop off in about 15 minutes and get going, but I'll be able to field some questions maybe en route. So again, Aditya Bagrodia, pleasure to be here. Here are my disclosures. None of them are pertinent to the talk. And our learning objectives today are really going to describe the benefits and limitations of PSA-based prostate cancer screening, identify men who are likely to benefit from prostate cancer screening based on risk factors and life expectancy, and then to provide a evidence-based approach, especially at the kind of primary care level for PSA screening, evaluation of an abnormal PSA result, including MRI, and our colleagues in urology. So prostate cancer, it's very, very common. You hear about it. We hear about it all the time. These are some adverts from the internet. Some of them are actually quite funny. And in addition to the lay press, we see prostate cancer in kind of high quality media. Here you see the New York Times, the Washington Post, Wall Street Journal. And every time, essentially a new study comes out in a premier magazine, we'll see it picked up by the press because it's so very common. And within our own community of urologists, there's some skepticism. So this is Willett Whitmore. He was the chairman of urology at Memorial Sloan Kettering. That's where Nirmesh and myself trained for fellowships. And a very memorable quote that the current state of prostate cancer may not be good medicine, but it sure is good business. And there are more people making a living from prostate cancer than there are dying from it. And we absolutely, of course, don't want that to be the case. So, what are our goals? Well, in an asymptomatic, clinically unremarkable men, we want to know, is there a cancer? And more importantly, is there a dangerous cancer? We don't want to screen everybody. A diagnosis of cancer, especially if it's not going to ever impact one's longevity, can lead to psychological harm. Biopsies, even though they're pretty safe, there can be complications, and then really significant treatment-related complications with respect to urinary health, sexual health, bowel health, oftentimes for cancer that would not lead to death. So we're really trying to shift towards smarter screening, smarter treatment. We want to screen people with a good life expectancy. We want to tailor the intensity based on race, family history, and a baseline PSA. Everybody with low risk disease, which I'll define shortly, should be managed by active surveillance. If we're going to treat, it should be high quality. And then to really accomplish these goals, it's a team sport with our epidemiologists, primary care partners, urologists, and the patients in the community. And here's what we're kind of doing. You'll see this slide over the talk a couple of times. Early baseline PSAs, if it's low, less than one, we're rechecking in 5 years, so you can kind of de-escalate the intensivity of screening. If it's moderately elevated, we engage in some shared decision making, look at risk factors, and consider a referral to your colleagues in urology. And then as we get older, the upper threshold is going to be a little bit higher at 3, but both of these are going to be well below the historical threshold of 4 for referral to urology. And I'll show where we kind of got that guidance from. So prostate cancer is the most common cancer in men. It's the second most leading cause of cancer-related death in men. So this is a very much a important health problem for people in our country. And we'll take a little historical perspective. In 2012, some of you all may remember this, prostate cancer screening got a grade D recommendation, which means the United States Preventive Services Task Force recommends against prostate cancer screening. And this was controversial. What did it do? We saw a decrease in the incidence of prostate cancer for the first time in many, many years. You can see this little dip down in 2012. And for the first time in a long time, we saw a flattening of the consistently declining curve of men with prostate cancer. We saw more patients developing metastatic disease. And why did this happen? Well, it was mostly our fault. And here is a quick history of PSA screening in one slide. Throughout the 90s and 2000s, prostate cancer screening was implemented poorly. Older men were overscreened, younger men were underscreened, low risk disease was overtreated, and high risk disease was undertreated. Despite all of these problems, mortality was driven down more than 50%, but at the cost of too much avoidable treatment-related side effects. And screening none was not the right solution. We needed to screen smarter. And PSA remains the best screening biomarker in the history of oncology. So there's been some screening studies. There's one in Europe, the ERSPC, the Gothenburg one, which is a subpopulation of that with extended follow-up, and the PLCO. The European studies showed a reduction in prostate cancer mortality. PLCO did not. And when we look at PLCO a bit more carefully, what we realize is that even in the unscreened arm, over 90% of the patients had at least one PSA. And it was really not a trial of screening versus no screening. It was traditional opportunistic screening versus standard screening. And essentially, the results of that are invalid. When you look at the larger studies, the longer term studies, you see it can take 15, 20 years for the curves to separate in a screen versus unscreened. But as you get further and further out, the arms continue to separate and the signal gets stronger. When we take the long view, we can actually save substantial numbers of lives, decrease the amount of overdiagnosis and overtreatment. And we basically know that 8, 10 year outcomes are not informative. We're looking at 20, 25-year outcomes to see the impact of screening and treatment for that matter. So what's the real problem? Over and under screening, over and under treatment. This is a study from 2015, and you can see that for men in their 80s, almost 30 to 40% of men are getting screened. That's going to be entirely too high when you look at kind of population level data. The likelihood of them having a 10 to 15-year life expectancy is quite small. We're making good progress in the use of active surveillance or monitoring prostate cancer with PSAs, MRIs, repeat biopsies. Still, considerable variability exists, and we can do better. So we're making good progress, but there's still some room for improvement. So we've seen prostate cancer screening using PSA once upon a time, and the question is, can we do it all better? So I share these guidelines quickly. There's the American Cancer Society, there's the NCCN guidelines, there's the AAPI recommendations. Here's our very own urology recommendations, which admittedly are quite confusing at first blush, but what we generally see is that we're moving towards consensus of risk factors. So African American ancestry, strong family history of prostate cancer and prostate-related malignancies, earlier baseline testing, and then if your evaluation is negative, shifting towards a larger interval between assessing again. And if you have a signal, we're moving into radiographic and other types of biomarkers. Screening rectal exams are no longer generally recommended. This was a change in 2023. So, barring any type of significant symptoms, rectal pain, you don't necessarily need to do a rectal exam if the PSA is normal. And you hear this term of shared decision making, it doesn't need to be burdensome. And it can essentially be boiled down to the goal of PSA is to identify aggressive prostate cancer while it can still be cured. Some people are at particularly high risk if they're African American or those have a strong family history. And screening may identify low risk prostate cancer, which is usually managed with active surveillance. And that's literally all that shared decision making requires. And again, here at UCSD, here's the screening paradigm that we've proposed, synthesizing all of the guidelines as well as the primary data. So practically, what does this mean? When a patient comes in, you want to ask about family history of prostate cancer, breast cancer, endometrial cancer, lymphomas, leukemias, or an African American ancestry. If they're lacking those, it could be considered standard risk. If they've got two or one of those, slightly increased risk. The life expectancy should be greater than 10 to 15 years. And if they're young with risk factors, essentially the urologists want to see them early. And at our institution, we will get an MRI prior, which can make for a more efficient visit and allow us to counsel the patients, particularly since that's the test that we would be getting next, almost certainly anyways. So when you get an elevated PSA test, any number of inflammatory conditions, recent sexual activity, excessive bike riding, subclinical inflammation, all of those can lead to elevations in PSA. And it's important to like let patients know that so they're not overly concerned when they see an abnormal result. So you've seen these numbers between 1 and 2, 1 and 3, where referrals to urologists are being considered. And where does this come from? So if you have a PSA less than 1 at the age of 60, the likelihood of prostate cancer related death is 0.3%, very, very small. So that's why we're checking early. If it's low, we de-escalate to 5 years. If it's high, we want to see it a little bit higher. If it's greater than 2 at an early baseline, that's where about 90% of the prostate cancer deaths are occurring. Those are the patients that we want to see. And here's the data that kind of supports that. You can see hazard ratios that are substantially higher when you have a early low baseline PSA, in the order of 5, hazard ratio of 5 and 2.7 for the highest decile and highest quarter, respectively. It is consistent across race, so this doesn't need to be adjusted depending on your patient population, and that's another kind of convenient element to it. So, when we are kind of thinking about the prostate cancer diagnostic and treatment algorithm, you get a PSA, and we have lots of tools in our toolkits that are helping us to not diagnose Gleason score 3 plus 3 equals 6, otherwise known as grade group 1 prostate cancer, and identify clinically significant diseases. This is mostly stuff that we're thinking about in our clinics. There's a variety of tests, urine-based, exosome-based, plasma-based, and then there's MRIs. And how do we best sequence that? This is a area of ongoing research. There's multiple proposals out there, and one day we hope to more closely engage our primary care providers. So when we look at like general criteria for screening, prostate cancer is an important health problem. It's the most common cancer in men. It should have a detectable preclinical phase. We're talking about screening with PSAs as opposed to physical exams or breast exams or testicular exams. Acceptable levels of accuracy. We've made good progress there. Historically, biopsies were done randomly using a variety of different systematic approaches. And absolutely, when you go that route, you can miss some of the tumors. You can undersample high grade tumors in red, oversample low risk tumors in green. These days, lots of exciting data coming through showing the value of MRIs, and this is going to be a standard per all guidelines. MRIs can allow us to safely avoid biopsies in about 30 to 40% of patients. We can make more specific targeted biopsies when we're performing a biopsy. And we can also look at the PSA index to the size of the prostate or the PSA density, integrating that into our counseling. The MRIs of the prostate are read with a PI-RADS score lesion, very similar to the BI-RADS lesion for a patient with breast cancer. This can be easily implemented as a dot phrase, and I think patients can understand it reasonably well. So accuracy looks pretty good. Cost, it's very expensive if you develop metastatic castrate-resistant prostate cancer. So cost is kind of easy. Justification. And then screening tests and follow-up should be acceptable to individuals and providers. Biopsies, these are done in the clinic, transrectal or transperineal, most of them shifting towards transperineal, and the complication profile is generally quite small. And then finally, we should be able to benefit patients when we intervene before the onset of symptoms. And this is honestly where the controversy lies. So the late translation is treatment should make a difference. We've got the PROTECT study, 1,500 patients, a third were monitored, a third received surgery, a third radiation. These are the type of patients that we see, PSAs of around 5, Gleason scores 1, grade group 1 and 2, primarily low clinical stages. And what we see is regardless of how you start out, prostate cancer survival, metastasis-free survival are relatively comparable. About 30 to 50% of patients will undergo treatment effectively, but we don't know that treatment benefits everybody. And our shared guidelines with other societies really suggest that the optimal treatment is unknown. You can do monitoring, you can do surgery, you can do radiation. And we really do try to monitor almost everybody with Gleason score 3 plus 3 equals 6 prostate cancer, regardless of tumor volume, regardless of age, regardless of risk factors. And you see that in the guidelines. Huge movement within our community to stop calling Gleason score 3 plus 3 equals 6 prostate cancer because it doesn't have the features of cancer. It cannot metastasize and misbehave. Um, so here again, as I've mentioned, we've tried to simplify it, start early, de-escalate if less than one, if between and three, depending on risk factors, take a closer look, consider getting an MRI and sending on to your colleagues in urology. So, bottom line, not screening is a head in the sand approach. A better strategy is to choose wisely who might benefit. Those with a family history of prostate cancer associated malignancies. Early baseline PSAs are very informative. And the goal is to offer screening to healthy men with good life expectancy, tailor intensity based on race, family history, and baseline PSA. Emerging biomarkers and imaging tests are going to be game changers. All low risk disease should be managed by active surveillance. Even yet, better to not diagnose it in the first place. And then when we do intervene, the quality must be excellent. So I'll stop there. And mostly due to some time logistics, what I might request is I'll go ahead and introduce Nirmesh and then hopefully be able to hop on to take some questions here towards the end. So one
Yes, go
question.
ahead. Go ahead. Introduce Nimesh, and then I'll. There's a couple of questions which we can feel. It shouldn't take that long. We don't have too many questions. So, why don't we just do that? Can you wait for another maybe less than 5 minutes?
Yeah, I'm gonna just let me go ahead and let me actually answer this question. So
Yeah.
after starting finasteride, PSA drops off dramatically. Does PSA monitoring lose its value? So it's an excellent question, and basically we can do a corrected PSA when patients are on finasteride. So if their PSA, for instance, is 3, we just double it to 6, and if
Yeah.
that's going to be kind of higher than an age-adjusted PSA, we would continue to kind of look into it with an MRI and so forth. And so when MRI is recommended, PSA still keeps rising. Yeah, so I think that hopefully answers it. It doesn't need to be the trajectory of the PSA once you're on finasteride. If that value's been above the threshold when corrected and remains that if retested in 6 to 8 weeks, for instance, I would go ahead and start kind of an investigation.
All right. So that's great. I don't think there's any other questions per se. But if there is any other questions before he leaves, please, or even after he leaves, if you have some questions, he'll be listening, I'm sure. But if there's nothing, you go ahead and introduce Nimesh. But if the, and I'll give you my comments before Nimesh comes on. But I can actually you don't have to. I can actually introduce Nimesh. That's not a so that's okay. So if you
Well,
want to leave, yeah.
let me do that. I'm gonna get moving here. I'm getting some looks
Okay,
here
go
from the
ahead. Go
gang.
ahead. Yeah, go
Thank
ahead.
you, thank you.
So Dr. Nimesh Singla is a associate professor of urology and oncology in the Brady Urological Institute at Johns Hopkins University, where he serves as a director of translational research and genitourinary oncology. He's also a director of the kidney cancer program and co-directs the upper tract urothelial cancer program as a founding member of the first ever UTUC multidisciplinary clinic. He's got a lot of other accolades that represents Sydney Kimmel Comprehensive Cancer Center, National Comprehensive Cancer Center, Testicular Cancer Guidelines Panel, and leads the Testicular Cancer Program. He's the vice chair and physician advisor of the Quality, Safety, and Service and faculty senator in the Department of Urology, and a core faculty member in the Hopkins Business of Health Initiative. Whoa, that was a mouthful. Like I said, I know Nimesh when I was a young kid. Used to come to all these conferences with his dad, who is a colleague of mine. Ajay Singla, very accomplished academic urologist in his own right. But here we always feel proud, and I cannot believe there could be a better day for this talk on a Father's Day when Nimesh is showcasing his thing for, and his father is listening to the comments. So great, Nimesh. Over to you. And then I will, before you go, before you start, um, let me just talk to you about this guidelines which he was talking about. Very funny story because I also do this talk on PSA guidelines. The UTSC United States Task Force recommendation came from a group of physicians, and they actually had a urologist in the panel, a urologist who makes a decision about whether to screen or not prostate cancer. And that urologist who was on the panel was a pediatric urologist. So I always say this in a tongue-in-cheek manner. Pediatric urologist making the only urologist in the panel who actually told people, I mean, that completely, really literally stopped the screening of prostate cancer. Till about 10 years later, we saw a spike in the mortality and metastatic prostate cancer. So that was and again, like he said, it was a grade D recommendation. I don't know whether you know the grades of recommendation. Grade D means somebody says, "Oh, I think so." That's it. Even it's lower than expert opinion. Expert opinion is grade C. Grade D is as somebody said that I think we should not. That's all. There's no other background to it. So that's why very quickly AUA had been touting against it that hey, cannot make a blanket statement. It is something which you need to weigh carefully one side or the other. And they were right. Urology Association AUA was right. Eventually they came back, and now we have got this informed patient. They had to maintain some kind of face, so they put that you have to make an informed decision with the patient. But Aditya put it very eloquently. That is all you need to tell the patient. What he just now said, that's all you need to say, and you'll be in the clear. Just document it. Just document it on your EMR, for medical records, that you had a discussion, informed discussion with the patient. Just do that documentation. Apart from that, you do what you think is right. Laid the guidelines, which are the low grade, which are the ones which you need to be concerned about, especially PSA rising. Somebody said, yeah, that's a thing with you. And there is something called PSA velocity. We used to use that before all these newer markers came in, before MRI came in. We used to use PSA density, PSA velocity. We used to use free to total PSA, which we still use in a different biomarker form. So we used to use that. Now MRI has made it very easy these days, because MRI can pretty accurately tell you whether this prostate cancer pyrites 4 or 5 are higher grade, etc., etc. So just a little bit plug in for you guys. And how often you see prostate cancer spreading to the spine? The first landing spot of prostate cancer, believe it or not, is the spine. And another difference in prostate cancer metastasis and any other cancer metastasis is that prostate cancer metastasis is sclerotic. In other words, other metastases are usually lytic, but prostate cancer metastases are sclerotic. So you find an increased density there. And bone scan is the first thing we order, even before a even before a CT scan, to diagnose whether it's gone to the lymph nodes. A bone scan is something which we order, but we have got some guidelines about bone scan also. We only do it for PSAs. I mean, there's a paper which shows that you should do it above PSA of 10, 20. Then they brought it down to 10. Now we do it also in highly aggressive prostate cancer, even if the PSA is low. If the patient has a Gleason 9 or 10, definitely I'll do a bone scan. So those are the small things. Can you discuss watchful waiting? Uh, where is the life expectancy of diagnosis totally depends on the Gleason score and how aggressive it is. And like I said, Gleason 6 cancers we consider like a skin cancer. So we can go on and observe that. When I was in residency, when we initially PSA came out, all the Gleason 6 we used to operate, all the Gleason 9 and 10 we used to send to radiation oncology, because we were afraid that we'd have positive margins. And the academic centers, they didn't like the data to show that. Now it's a 180-degree turn. Gleason 6s, we don't do anything. Gleason 9 and 10, we aggressively treat either with surgery or radiation or a combination of both. Um, any preventive measures? The only preventive, they have tried all kinds of studies. They've tried selenium, leukophins, vitamin, all the things. Nothing has been shown except for high fatty diet. High fatty diet is only thing which is vaguely linked to it. Of course, the most strongest link is family history. African Americans and family history are the strongest link. So preventive measures, just healthy diet and exercise is how you can prevent. Watchful waiting and risk. So watchful waiting is a very, very interesting thing. Watchful waiting is whether it's after biopsy, when you have the biopsy. Initially, when AU recommended watchful waiting, they recommended that you should repeat a biopsy in 1 year because they were not sure that we're treading down the wrong path like the UTSC did 10 years ago or 20 years ago. So we advised a repeat biopsy in 1 year. Now they have said that, okay, repeat biopsy is not done in 1 year. Maybe you can wait for 2 years. But we are still very, very careful in following the PSA. So even if you're doing watchful waiting, you're following PSA very closely and you're doing it with a complete informed person. The point here is that when you have prostate cancer and you're in watchful waiting, it takes a toll on the mind of the patient because he knows that he's living with a prostate cancer, which can be deadly. And the second largest killer amongst American males is prostate cancer. So this thing, and Tarak might hit on this, is an anxiety. You become what's called a PSA addict. We call them a PSA addict. They ask for a PSA almost every month. So those are the things you need to take into consideration before proceeding any further. So there are no other questions, I think. So I don't have any comment on President Biden's delayed diagnosis. I'm not quite aware exactly why it happened. I don't have. Pain control. Pain control is, somebody asked, we give steroids, actually. Prednisolone works good for metastatic prostate cancer. We can radiate that area, and sometimes that helps. Or we can actually have the strontium and stuff like that. We used to give IV. We don't use that much now. PSMA guided stuff is also coming up, and I'm not completely sure about it. But pain control we do with spot radiation and spot radiation and prednisone towards the very end of the patient's life. All right, so I think we have covered everything, and go ahead, Nimesh, over to you, buddy.
All right. Well, thank you so much, Amit. Really, your comments were so kind, and maybe more than I deserve in terms of how kind you were. But I appreciate the introduction, and I'm really honored. And thank you so much to the to AAPI for this invitation to present. So I'm going to shift gears a little bit and talk about hematuria, which is another of the most common forms of referrals that we receive as urologists, and something that is very commonly seen in the community, and most of the time may get picked up by a primary care physician.
Nirmesh, can you come closer to the microphone or raise your voice? It may be a little bit hard for people. Yeah.
Sure. Let me know. I'll try to speak a little louder. If not, I can just use the computer microphone.
Sure.
Okay. So for the purposes of this talk, I have no relevant disclosures. So for today's objectives, the plan will be to first talk about different forms of hematuria and their etiologies, describe evidence-based approaches to evaluating patients with hematuria, and then finally, I have a couple patient case studies that I think will be helpful to maybe place this into context. So just to start, so hematuria comes essentially in two forms. Broadly speaking, it refers to the presence of red blood cells in the urine, and can be defined as either gross hematuria or microhematuria. Simply put, gross hematuria refers to hematuria that's visible to the naked eye, so patients will see blood in the urine, or microhematuria, which is defined as at least 3 red blood cells per high-powered field on a single urinalysis. Now, it's important to recognize that this must be done on a microscopic urinalysis assessment, not simply just a dipstick testing alone, because of the risk of false positives. That's not always reflective of the presence of red blood cells. And there are some certain parameters with respect to proper specimen collection and processing, the important thing being that this is a midstream clean catch specimen. And I'll be focusing primarily, since we do have a national guideline that's evidence-based, a lot of what I'll be discussing today is reflected in our American Urologic Association microhematuria, asymptomatic microhematuria guideline that was recently amended last year. So as far as what causes blood in the urine, the thing we always, as urologists, want to keep an eye out for would be what are the life-threatening concerns, and specifically this boils down to malignancies. Among the types of malignant etiologies for hematuria, the most common thing that we think about would be urothelial cancers, specifically bladder cancer, or even cancer that arises from the upper urinary tract, including the ureters or the collecting system of the kidney. But also kidney cancers arising from the cortex of the kidney, and in some cases, more aggressive forms of prostate cancer can also be malignant sources of hematuria. In general, roughly between 15 to, depending on what source you look at, anywhere from 10 to 20% of patients who present with gross hematuria may have an underlying malignancy as the source, whereas that rate only drops down to about 3% of patients with microhematuria. And so there are certainly a number of other etiologies as well that form actually the majority of cases of hematuria, ranging from UTIs, other sources of inflammation, stones, BPH, other anatomic abnormalities or glomerular sources that would be best evaluated from a nephrologic lens. And then there's also something called benign hematuria, which can be sometimes induced by excessive exercise, for example. And I mentioned the importance of having a proper microscopic assessment of a urinalysis to define hematuria, because there can sometimes be confounders on a DIP test or even on a urinalysis test. One can see sometimes gynecologic sources causing contamination of a urine specimen. The presence of myoglobinuria can also have an appearance of a gross hematuria, and there are certain foods and drugs that can also sometimes amount to pigmentation within the urine. I'll just share an at-a-glance assessment of bladder cancer. So as it stands, bladder cancer is the 6th most common type of cancer in the United States, amounting to roughly 85,000 new cases this year. It's expected that nearly 18,000 patients will die from bladder cancer, with an amounted 5-year survival rate of close to 80%. It generally tends to be a cancer type that affects an older population with a median age of diagnosis at 73. So when evaluating a patient with hematuria, first and foremost is the importance of doing a proper history and physical assessment. Specifically in the history, it's important to assess risk factors for both malignant and non-malignant causes, which I'll go over momentarily. Also assess for the potential for any medical renal disease, and in women, gynecologic history as well. To assess for nephrologic etiologies or any other underlying renal issues, it's important to make sure that the blood pressure is assessed, and to assess at least a basic metabolic panel to include the creatinine. Now, it's important to recognize that even in the absence or presence of the use of anticoagulants, the assessment remains the same. So sometimes patients who are on an anticoagulant that have hematuria may be sort of overlooked or thought to say that, this is maybe just simply due to the anticoagulant. But really, it's important to recognize that there may be some other underlying cause that could be unmasked, let's say, by the use of an anticoagulant. So it's important to assess all patients the same, regardless of this use. If it turns out that a non-malignant cause or a gynecologic cause is diagnosed, it's recommended to repeat a urinalysis after proper assessment, treatment, and resolution of that particular etiology to see if there may be still persistent hematuria that would warrant further evaluation. And the AUA now, as of 2020, when they released the update to the microhematuria guideline, has defined certain risk-based criteria for diagnostic assessment. And in particular, this pertains to how best to evaluate both the bladder and the upper urinary tract. And I'll talk about this in just a moment. But it's important to recognize what are the risk factors for a urothelial malignancy. I've listed them here. They come from, again, they're listed in the microhematuria guidelines and largely evidence supported over the course of decades now. The most common risk factors include age, older age, male sex, use of tobacco, the extent of hematuria, the persistence of microhematuria, and then anyone who has gross hematuria, again, has a higher risk of harboring an underlying malignancy. While ascertaining one's history, it's important to also assess for additional urothelial risk factors, including irritative urinary symptoms, a prior history of radiation to the pelvis. For those who have received prior chemotherapy, those who have received specifically cyclophosphamide or ifosfamide based regimens, those who have a family history of urothelial cancers or genetic predispositions, specifically Lynch syndrome or HNPCC, which often presents with colorectal cancer. Those who have other occupational types of exposures, so specifically to benzene chemicals or aromatic amines, that's often found in certain dyes, sometimes some certain cleaning agents. So those who, for example, have worked as a cleaner for a long period of time, or who have maybe been exposed to dry cleaning agents for a long period of time, if they work in a laundromat or something to that effect. These are patients who may also have an increased risk of developing urothelial cancers. And then there's also patients who have chronic indwelling catheters in the urinary tract as well that may be susceptible to increased risk of malignancy. So I'll go over this in more detail, but in general, the guideline now has stratified patients into three risk categories, including low or negligible risk, intermediate risk, and high risk categories. And the reason this is important is because we have now taken an approach where we have tried to de-escalate as a field the approach to evaluation, because in general, historically, the sort of standard approach to everyone would be cystoscopy, as well as a cross-sectional axial upper tract imaging of the abdomen and pelvis that includes excretory phases. So in other words, a CT urogram and a cystoscopy. Now we have de-escalated this a bit, where we are trying to maybe reduce the amount of cystoscopies, which of course are invasive procedures in patients based on their purported risk. And when we're talking about risk, what I mean is starting with the low and negligible risk category. If patients meet all of these criteria, in other words, they're younger in age, and this is again gender stratified, no prior history of smoking or limited history of smoking, simply have a low degree of microhematuria and no other risk factors that I showed in a previous slide. These are patients where one could consider repeating a urinalysis within 6 months. Not always do they need to undergo an immediate cystoscopy or imaging, although certainly this remains an option. And then if these patients have persistent microhematuria, then this automatically reclassifies these patients as either an intermediate or high risk group. For patients who fall into this intermediate risk category, these are patients who might be a little older, maybe a greater degree of tobacco exposure, a significant, more significant microhematuria on a urinalysis assessment, other risk factors for urothelial cancers, or again, persistent microhematuria. These are patients in whom a cystoscopy would be warranted, as well as some form of upper tract urinary imaging. And in general, a renal ultrasound would be acceptable in these patients, although again, certainly there's no harm in getting cross-sectional axial imaging if one were to sort of consider a gold standard approach. Now, if this is a little bit of a shared decision making to be had with the patient, but if a patient were very hesitant about pursuing a standard of care cystoscopy, one could offer urine cytology or urine-based tumor markers to guide the utility of a cystoscopy. And I'll go over some of these tests in the next slide, but it is important to recognize that these are not perfect, and in some cases can be considered still investigational or experimental. And so still cystoscopy would remain the gold standard in these patients. And I would say that additional urine-based testing would be best served as an adjunct if pursued. If patients do forego a cystoscopy, however, then at the very least, repeating a urinalysis within 12 months would be warranted. There are a number of urine-based biomarkers that have entered the market, and there are more certainly under investigation now that I have listed here with a variety of performance characteristics. Again, it's important to recognize that these are not routinely used to decide on cystoscopy, especially for low or high-risk patients, and it's not routine to use them as an adjunct to cystoscopy, since really cystoscopy or direct visualization remains the gold standard when evaluating the lower urinary tract. In patients who have high-risk disease or equivocal cystoscopy or persistent microhematuria or irritative symptoms, these are patients in whom a cytology can be acceptable, usually as an adjunct to direct visualization if that hadn't been performed at any point. And then high-risk patients are those who meet any one of these criteria, particularly older males, greater than 30-year pack year smoking history, more substantial degree of microhematuria or gross hematuria, and then any other risk factors that were identified on a previous slide. These are patients who really should undergo a cystoscopy and some form of axial imaging. The preference is typically to get a multi-phase CT urogram. That would include typically a non-con phase, an arterial phase, a venous phase, and then a delayed or excretory phase that would illuminate the collecting system and upper urinary tract. This is important because the goal here would be to evaluate for any other potential sources of hematuria that have originated within the kidneys or the ureters. In patients in whom a CT-related IV contrast, iodinated contrast, is contraindicated, an MR urogram would also be acceptable. And then as an alternative, patients may also undergo a non-contrast axial imaging or an ultrasound in conjunction with retrograde pyelograms, which would typically be performed by a urologist if there is some reason why a patient is unable to get either a CT urogram or an MR urogram. In terms of follow-up, if a patient were to have a negative evaluation for microhematuria following a shared decision-making, there can be repeated urinalyses performed in the future. And I've listed some of the algorithms that have been suggested through the AUA here. If a repeat urinalysis is negative, it's reasonable to forego any further evaluation. If there is a positive microhematuria, or in other words, persistent hematuria on a repeat urinalysis, then further evaluation should be predicated on shared decision-making. And then if a patient were to progress to gross hematuria or an increased degree of microhematuria or new symptoms, then evaluation is recommended. So I'll pivot to a couple real-life patient cases just to provide some context for how we, as urologists, will see these patients and how it's important to sort of be a good partner, how to partner as a urologist with our colleagues in primary care, because again, most of these patients will often be first vetted through a primary care type of a practice. So the first is a 75-year-old Caucasian male who presented initially with asymptomatic hematuria. Very much asymptomatic, no other urinary symptoms, no abdominal or flank pain. However, he did indicate that there was about a 17-pound weight loss over the course of 10 months. Aside from hypertension, no other remarkable medical history. He is on aspirin, but otherwise no known family history, retired veteran, 50-pack year smoking history, and the physical exam was essentially unremarkable. On a laboratory evaluation, the urinalysis was not too remarkable. There was maybe 3 to 5 RBCs per high-powered field, no RBC casts, so perhaps this was a scenario where there was just an isolated episode of gross hematuria, but one that was perhaps more intermittent in nature, that's not always captured by a screening microhematuria that's not always captured with more significant degrees of microhematuria. And so it's important to be able to recognize that even in the presence of a small degree of microhematuria, it still warrants some form of evaluation, especially when there's other risk factors that are present. Really nothing to remark otherwise in terms of his serum evaluation. So he was referred to a urologist. Cystoscopy was performed that really didn't show anything obvious within the bladder or the urethra. A cytology was obtained because of the higher risk profile for this patient, and it was relatively nonspecific. It came back as atypical cells, which can be interpreted in a number of ways, but in general, we often see this as a nonspecific entity, since many benign causes can also result in atypia when a cytology is assessed. So because of his risk, he did undergo a CT urogram. And again, I mentioned that it's important that there are multiple phases performed. When looking at a non-con phase, I've shown a few axial cuts here. It may not be readily apparent that there's anything that's obviously wrong here. There may be some fullness to that right renal pelvis, but otherwise there wasn't anything. I'm not showing kind of the full spectrum of the urogram here, but we didn't see anything really in the ureter or in the lower tract. But again, I mentioned the importance of ensuring that there's a delayed or an excretory phase, which I've shown here, because what's now very apparent within the right urinary tract, specifically within the renal pelvis, is this large filling defect or tumor that has occupied most of the volume of that renal pelvis. And you can see some of the contrast making its way around the tumor as it's entering in just past the ureteropelvic junction, as shown by the arrows here. And so, as a result, this patient did undergo a ureteroscopy, and sure enough, there was a very large papillary appearing tumor in the renal pelvis, which was biopsied and consistent with essentially a sister of bladder cancer called upper tract urothelial cancer that sometimes can be very difficult to diagnose, but really relies on the aptitude of really doing an evaluation, even in the setting of just a low degree of microhematuria in the right patient. And sure enough, this patient had high-grade upper tract urothelial carcinoma and ultimately was treated with the gold standard approach, which was an extirpative surgery, essentially a radical nephroureterectomy, which entailed removal of the kidney and the ureter. And if this weren't diagnosed, this could become certainly a life-limiting diagnosis with a poor prognosis. But again, the importance of making sure that a proper evaluation with excretory imaging from an axial phase CT urogram would be important to ascertain in order to catch a diagnosis like this. I have one other case that I'll present here. This was actually one of my colleagues had managed this patient, and so I thought it was worthwhile to share. This was a 57-year-old Caucasian male who was actually admitted with gross hematuria and was also noted to have a UTI. But of note, this was a spinal cord injury patient with quadriplegia and neurogenic bladder, managed with a chronic indwelling catheter that was exchanged monthly. He had sustained a C6 SCI at a relatively young age. He did have issues with bladder stones in the past and underwent a procedure called a cystolitholepaxy, where the stone was treated endoscopically. But otherwise, no history of upper urinary tract stones, no history of malignancies as far as the family history is concerned. And in general, the physical exam was relatively unremarkable with the extension, with a few exceptions. There was some distension, particularly in the suprapubic region, and there was a catheter in place draining dark red urine as advertised. So this patient had actually been admitted and was empirically started on antibiotics and actually was having issues with maintaining his hemoglobin, and so did require transfusions with hand irrigations of his catheter due to the formation of clots, and actually did require initiation of continuous bladder irrigation, which is something that we sometimes need to do for our inpatients with significant hematuria causing clot obstruction. He was anemic but had a normal creatinine and normal coagulation parameters. So this patient also underwent a CT urogram, and the urogram revealed the following. And I've just sort of shown some representative cuts here, and I'll sort of indicate what the radiologist had read, which was essentially this gross appearing clot adjacent to what looked to be a mass near the bladder neck, towards the base of the bladder. So again, these are some images that showed this. No upper tract filling defects were seen, some thickening of the bladder wall, but aside from this, really the main finding was this mass that was detected. So he was taken for a cystoscopy. There was a clot evacuation that was necessitated, but there wasn't actually a bladder tumor seen, but rather a significant enlargement of the prostate with a very large intravesical median lobe. And due to the degree of hematuria, transfusion-dependent hematuria that this patient was experiencing, and the significance of the intravesical lobe with clear bleeding at the time, my colleague had performed a transurethral resection of the prostate to help manage the hematuria, as well as this sort of BPH issue, albeit the neurogenic bladder also confounded the picture of his retention. And in particular, the median lobe was what was resected, because that was felt to be the main culprit for the hematuria. And so I will just make a mention that BPH is often a common cause for hematuria, and in fact, more than 10% of patients with hematuria, and this is probably underreported, may have hematuria secondary to the BPH. It's relatively uncommon, but in less than 2% of patients, sometimes patients with BPH may have gross hematuria that would be transfusion dependent. And oftentimes this is due to the extent of vascularity that exists within the prostate, especially in those that are enlarged. There are non-surgical ways and surgical ways that gross hematuria from BPH can be managed. For those who have a longer sort of time horizon with less acuity, a drug like finasteride, which I know was mentioned earlier in the talk related to PSA, can be used to help shrink the prostate over time. But then there have been other methods, including aminochlorotic acid, use of androgen deprivation, surgical approaches, as was pursued in this case, and prostatic artery embolization, or PAE, which can be pursued by one of our interventional radiology colleagues, are some of the approaches that we as urologists think about, but there are certainly others as well. So on that, I'll just stop here. I just wanted to present a general kind of overview of the approach to hematuria, micro and gross hematuria, and sort of our now risk stratified approach that we as urologists undertake. But again, at the end of the day, it involves a close partnership between us as urologists and primary care physicians to really pick up on sometimes life-threatening diagnoses as well as other benign causes for hematuria. So on that, again, I'd like to thank you for the opportunity to speak today on this topic, and would be more than happy to facilitate any discussion or answer any questions.
Very great, Nimish. It was awesome. I mean, I've heard you speak so many times, and as usual, you did a great job. Dr. Madhya, a question about urinary incontinence post robotic prostatectomy. Obviously, it's not under this thing, but if you allow me, I can answer and push it back to Nimesh if he wants to. But basically, urinary incontinence after robotic prostatectomy depends on how long it's been and how severe it is. So basically, if you have robotic prostatectomy, now you may, for the first 3 months to 6 months, you may have some urinary incontinence. Definitely for the first few days. It gets better as you go along. We advise you the same old routine Kegels exercises, and I advise my patient to go and stop and start when he urinates, and same muscle, because it's very difficult to explain to the patient what is a Kegels exercise. So I tell my patients that when you urinate, stop and start your urination. If you can do it, that's good news. And the same muscle which you use to stop and start urination, you need to squeeze, 10 seconds, 10 to 15 seconds, and let go. Do it 5 times in a row, 10 times a day, which is 50 times. Okay, so that is what we do. That helps sometimes. Plus, it actually gives you something to do while you're waiting for it to get better. And these days with robotic prostatectomy, people do a very good approach where they spare the sphincter, they spare the nerves, and the recovery of incontinence is better, and the incontinence rates are lower. Now, some people have bad incontinence. This is where you need to make a distinction, which a lot of urologists, even urologists, I might say, would jump into saying that, okay, we'll put a sphincter or a sling. I'm going to come to that. So if a patient has urinary incontinence, you need to make sure it is stress incontinence, not urgent incontinence. Why do I say that? Well, because if a patient has an enlarged prostate, your bladder, which is usually thin-walled and elastic, gets thicker because it has to push against the blockage. It's like bladder going to the gym. So when it becomes thicker, it becomes less compliant, less stretchy. Okay. So when it becomes less stretchy, then when you take the prostate out, they may have urgent incontinence. So that is something which you shouldn't treat with surgically, because you can treat with medication to slow the bladder down. Now, if it is stress incontinence, that happens when you get up from a sitting position, cough, sneeze, laugh, and you waited a long time. Depends on how severe it is. If you waited for a long time, then you can offer them male sling, which is called advanced male sling, which you can, like a female sling procedure, we can do that. Or the gold standard that's been there for more than 50 years, artificial urinary sphincter. that is something which we can do. Again, this is another question. U.S. ultrasound is not good for hematuria evaluation. Urologists always want a CT scan. I'll pitch it back to Nimesh. Can you answer that question?
Sure, absolutely. No, it's a good question, and historically, it would be the case that really anyone who would walk in the door with microhematuria would be recommended to undergo a cystoscopy and a CT urogram. And this was sort of in the prior iteration of the guideline, and since then, if you recall, as I mentioned, just 3% of patients with microhematuria are actually found to have like a malignant source for the hematuria. So there had been actually a host, I didn't show it in this, in the interest of time in this presentation, but there had been a number of cost effectiveness analyses performed that sort of evaluated whether this empiric approach should really be used for everybody, or if there's an opportunity to de-escalate the approach to hematuria evaluation based on risk. And so based on this notion, it was certainly I would say for those who have kind of this higher risk profile, it's absolutely imperative to do axial cross-sectional imaging. But for those who sort of fell into that intermediate risk category that I reviewed, it is acceptable to pursue a renal ultrasound. And certainly if there's any concerns or if there's a desire instead to sort of go with a more traditional gold standard approach, no one would be faulted to pursue like a CT urogram or an MR urogram for the most comprehensive assessment. That is true. So I would say the intent of de-escalating is sort of couched in a combination of cost effectiveness as well as the kind of incidence by a risk stratified approach of a malignant etiology. But when in doubt, certainly a CT urogram, if a patient is eligible to undergo one, would be the most sensitive test.
Great. A question which was posted a little earlier, and I'm not sure it's posted for prostate cancer or hematuria, but I will answer both ways. Any comments on the new genetic tests? Well, I will talk about prostate cancer. There are new tests which actually look at mRNA and to make the specificity of elevated PSA much more better, because as Aditya spoke about earlier, we know that they are bad actors. We just have to distinguish who are the bad actors from the good actors, so to speak. So that is why I have explained to you earlier, we had PSA density, age-specific PSA velocity, all these things were the criteria, then came free to total PSA. Now they have got molecular markers, and they actually do that. There is a 4K score and PHI. Then the recent thing is ISO-PSA. ISO-PSA actually picks up the PSA, which is produced by prostate cancer cells, and that shows promise. So those are the things which people do. But MRI being available so readily these days has kind of trumped those things a lot. So that is something which is there. But like I said, MRI has kind of trumped some of those tests. But if a patient's PSA is elevated and it's you did a biopsy, it's negative, and you want to make sure all the patient's PSA is elevated, he's not sure whether he should go for a biopsy or not. Rather than doing an MRI, we can do one of these tests. It actually tells you how great is his risk. After having said that, now I want to pitch it over to Nimesh to talk about any genetic markers for bladder cancer.
Yeah, absolutely. So it is actually a very hot area right now. Urinary tumor DNA has already actually been evaluated in a number of contexts, and actually we're in the midst of seeing more such tests, commercialized genomic platforms, essentially being utilized in different in different sort of contexts for bladder cancer, ranging from screening and diagnosis to therapeutic monitoring, among others. I showed a slide earlier that went over some of the urine-based biomarkers that have been explored for at least for screening purposes. And in general, they would still be inferior to direct visualization through cystoscopy, for example, but can sometimes be useful as an adjunct, the most common being urinary cytology, which would be essentially looking within the urine to assess for abnormal morphology of cells. And then there's also fluorescence in situ hybridization or Eurovision testing that's done often as a reflexive test in some contexts to the cytology that adds a little extra specificity. The problem with these tests in general is that they often lack the sensitivity to be able to be used alone. And so that's often why we can't just simply rely on them as a non-invasive test. There are a number of companies who have been developing various urinary genomic-based testing platforms. I would say that probably the most encouraging one at the moment is something called CX Bladder, and this again is a proprietary genomic platform where it's being explored to essentially try and supplant cystoscopy surveillance in patients, and they have a couple different tests. One's called CX Bladder Resolve, one is called CX Bladder Triage, and the idea is whether we can use these as either a screening test in patients to avoid a cystoscopy. And right now it's something that is being advocated for by some in patients who fall into that intermediate risk category that I was discussing. But then in other contexts, it may be an opportunity to de-escalate the cystoscopic surveillance for patients who have non-muscle invasive bladder cancer that are undergoing intravesical treatments, where they were basically sparing their bladder and trying to do periodic cystoscopies to monitor for recurrence. And so in these patients, there has been found to be some utility in perhaps performing less frequent cystoscopies and integrating the use of these types of tests, which are genomic based. So it is actually a very exciting time, and we're seeing refinements of various genomic assays where we can non-invasively learn more from just the urine alone for patients with urothelial cancers.
Answer. Another comment which I may like to comment on that, because I also give a talk on overactive bladder frequency. Yeah, it's a reflex. If you hear running water, you feel like peeing. It happens to people who have urgent incontinence, it happens worse, people who have urgent incontinence, but it happens pretty much with everyone, even if you don't have urgent incontinence. Another very interesting thing which I can say from this, how many of you know what's called a key in the lock syndrome? Key in the lock syndrome is a patient with urgent incontinence will not have any urgency or leakage, even if while driving home. But the moment I'm saying she because it's commoner in female, moment she puts the key in the lock, just trying to get into the door, she'll have the urgent incontinence. That's because it's just a mind bladder reflex. So what I tell my patients, and that this in my talks, I don't know, for some reason, people who have heard my talks on overactive bladder always remember this part. Well, I tell them that if you have urgency or urgent incontinence, urgency, to prevent leakage, you try to walk backwards to the bathroom. Let me listen to this also. Walk backwards to the bathroom because you're more concentrating of not falling, not tripping over, and your urge goes away. So that's what I have always I've tried. And somehow, whenever I meet my colleagues, anybody who has heard my talk says that, hey, you know what? I tried walking backwards to the bathroom. So that's something which also helps. So it's a mind over bladder kind of thing always. Whenever you have urgency, think of something else, or the urgency goes away. Whenever you have urgency, don't try to raise the bladder. Bladder will win. Try to suppress the urge and then walk to the bathroom. So if you run to the bathroom, bladder usually wins. So any other questions? We don't have. We've got another maybe 15 minutes to talk. I can, like Dr. Chirnamula posted, doesn't have to be on these two topics. If you've got any urological questions, we'll try to field those questions. So go ahead and put any urological question. By the way, if Ajay is on the call, on the Zoom, you may unmute him if you can, Ajay Singla, because he's an expert in urinary incontinence. He's a university professor, and if he wants to add a couple of lines there, I would welcome him to do that. Ajay, are you there? Vijay, can you unmute Ajay Singla, please?
Find him. I couldn't find him though.
Oh, you can find him. Okay, so he must have left. Okay, anybody else has any other urologist question? This is your chance. Anything which is, you always wanted to know why and how. What are the, okay? All right. Very practical and appropriate talk on Father's Day. Thank you so much, Sunil. What are the advances in erectile dysfunction? Again, since Viagra, Viagra has, obviously there are the medications that came out, but basically it's a PD5 ingredient. So Viagra is something which is the gold standard, okay? So if you have got minor, but remember, after Viagra came out, there were more people were fearing that nobody would get penile prosthesis done. But believe it or not, about 3 months or 6 months after Viagra came out, incidence of penile prosthesis actually went up. And guess why? Because it was very heavily advertised in the media. People who thought that, it's all gone, we cannot, that's it, now realize that, hey, there's a pill available out there. Let me go and try it. So they go to the doctor, they try Viagra, and as you know, 20% of people, Viagra does not work. Because Viagra needs an adequate blood flow to keep the erection. What does Viagra do? Prevents the breakdown of nitric oxide, which actually relaxes the sinusoids in the penis and allows the blood to flow and fill the penis. So it keeps it erect because of that. But if you don't have enough nitric oxide or you don't have enough blood flow to the penis, then Viagra will not work. So for these patients, there are 3 other options: vacuum erection device, and that's been there for years and years and years. Vacuum erection device, non-invasive but cumbersome, penile injection, where you actually inject prostaglandin into the penis, which gives an erection, and the erections last about 2 hours. If it lasts anything longer than that, you need to go to the emergency room. Very important about that. Can cause priapism, not that common, but it does cause. And then penile prosthesis, where you actually put in cylinders, inflatable cylinder in the penis, and a pump in the scrotum. So penile prosthesis is the long-term gold standard, and patient and partner satisfaction rates are very high with penile prosthesis. However, it's an invasive procedure, has its complications. So, any thing you want to add, Nimish?
No, I think that was fairly comprehensive. Just the oral PDE5 inhibitors, and then penile injections, vacuum pump devices. There was also something that was developed that was an intraurethral, essentially, agent that was not as well received because it caused a lot of penile pain. It's called Muse. So it's not really used much these days. But then kind of the last resort option would be implantation of the penile prosthesis.
Can you speak up a little bit next time? So
sure.
basically there are also now newer things like stem cell and stuff. They're all investigational. They're not out in the market yet. So these are the gold standards. I don't think there's anything else where you can think of right now. So there used to be something called Muse, which is actually intraurethral prostaglandin, but it requires a lot higher dosage and was not as effective. So we still use Muse because when you put penile cylinders or when you put do injection, let's say you put a penile prosthesis, the corporal bodies are stiff, but the glands is soft. So if you want the glands also to get some tumescence, people still use some Muse for that. That's the only time I use Muse, which is intraurethral prostaglandin. As Flomax, any valiant females? Yes. So let me answer that, and I'll let Nimish or Ajay, if he's back, can answer. Nimish, text Ajay
Sure.
if he can join back. Okay.
Sure
So
thing.
so Flomax. Flomax, as you know, is an alpha blocker. It blocks the prostate is a fibromuscular glandular organ. So fibromuscular glandular organ. So people initially thought that, oh, the big size of the prostate was constrict the prostate. So they went on the Proscar route, but we realized the Proscar Avodat are not good, not immediately effective, because that is not all usually what the enlarged in a prostate size doesn't matter. So enlargement of prostate per se does not cause necessarily your symptoms. They quickly realized that the muscles which the prostate has, that's what causes the symptoms. So alpha blockers are things which actually relax that. Why is it given on females? Well, Flomax also has effect on bladder base. So alpha blockers for the prostate, for some of the females still have some degree of, so it can improve the emptying of sometimes it's shown to improve the emptying of bladder if you use Flomax, because there's no other medication. Bethanical we used to have before, and it's been proven to be just like a placebo. We used to use Bethanical a lot before, but please understand, primary care doctors, we don't use that because Bethanical is just like has been compared to a placebo and it's no different. So essentially, we don't have any medication for improving the contractility of the bladder. We have other methods where we can do InterStim or peripheral tibial nerve stimulation, which actually InterStim can work in helping the bladder. But there is no other medication which can actually help you empty the bladder. So that is the reason when you don't have anything else in your hand, we sometimes give Flomax, and it's shown to help, but not as drastically as for males. Nimesh, any comments?
Yeah, so that's exactly right. So the idea is that with the use of the alpha blockade, there are sometimes women who have these tight pelvic floors, essentially what we call pelvic floor dysfunction, and there may be some opportunity to help relax the involuntary smooth muscle, who have a more hypertonic pelvic floor, to help reduce the resistance at the urethra for voiding. And actually, my dad happens to join the call again, and is an expert on this. And
Yes,
absolutely
Vijay, can you unmute Ajay? So Ajay is an expert on incontinence and pelvic floor disorders and all those things. So we had several questions on incontinence, buddy. I was reaching out to you for help, Ajay. So
Okay.
if you go over the chat box, and read the questions while I answer the next one, and then you chime in and answer all those questions with us. I did what I told them, but you can add to that. Does beta agonist cause dependency? I have not had any patient of mine who was dependent, in the sense the only dependency they can say that, hey, I want to continue because that helps my urgency. But apart from that, I don't. Yes, the symptoms can get worse. It is helping you. It's a lifelong thing. So beta agonists are mid-metric. Everybody knows mirabegron, and the newer one is Gymtesa, which is mirabegron. That's a little bit less side effects, no dose titration. Only drug interaction is with digoxin. So it's a very, very safe drug, Gymtesa, and I don't think that any other withdrawal symptoms apart from there. So.
Sorry, I got disconnected, somehow. I don't know what happened, but
Oh, that's
no,
fine.
I'm back.
So
Sorry,
can you answer a few, give your comments on a few of the questions above? I've tried to answer any of the incontinence questions, especially. I tried to answer.
Yeah, I saw the male incontinence earlier, then I got disconnected while the discussion on male incontinence was going on, and then you guys had a female stress incontinence, Amit, after that?
No, we're talking about, there was no female stress incontinence question per se. They were asking about Flomax you give sometimes for incomplete bladder emptying for females sometimes, you know. So what is the
Oh,
rationale for that?
yes, that's true because we have used alpha blocker when there is a female bladder outlet obstruction that can happen in primary bladder neck obstruction in female. That is a known entity and it can happen, which is diagnosed really only by the video urodynamics. And then you can try alpha blocker, and if that does not succeed, sometimes we have to give bladder neck incision, which is a surgical treatment to incise the bladder neck to open up so that they can void and empty their bladders. Yes, that's correct.
Great. Well, now Nimesh, Ajay is here. So any other incontinence question he can answer. Let me answer this question about alpha blockers. Somebody commented alpha blockers may have adverse effect on glaucoma. I don't think alpha blockers has any effect on glaucoma as far as I know. Ajay can
No.
correct me if I'm wrong. It doesn't.
No.
What you're talking about is anticholinergic medication, and
Correct.
anticholinergic medication causes that, and you cannot give it on closed angle glaucoma. Open angle glaucoma you can still give that, but closed angle glaucoma you cannot. And mirror background, is not a new kid on the block. It's a very, very old kid. It's there for about 7 to 8 years. The new kid is, I told you, mirror background, and that has got no side effects on glaucoma or any other anti-muscarinic side effect. But Flomax, one side effect was, and this you guys need to understand, is that it causes floppy iris syndrome. So ophthalmologists didn't like it when they tried to do urine Flomax, and a person has cataract, and you go and get the cataract removal done. They used to have tough time, but now they have come across. I talked to my ophthalmologist colleagues. Now they don't bother about it that much. They can was a very big thing initially when Flomax came out and they encountered this thing, but nowadays it's not that important. Flomax side effects is alpha blocker, so orthostatic hypotension, something which is so if patient has suddenly gets up from sitting position, he may get a little dizzy. So I tell them to first try it and don't drive and take it easy at home and see how it works. Flomax is given at 0.4 milligrams, but we frequently go up to 0.8 milligrams. And it's particularly important to tell the patient to try it, make sure he doesn't have orthostatic hypotension before we increase the dose. Over to you
Yes.
again, Ajay.
Yeah, no, you're absolutely right. In men, sometimes the retrograde ejaculation, it can be a concern
Yeah.
for the patients because when you block the alpha blockers and it open up the bladder neck, and so the semen or ejaculate can go reverse in order, that can go back into the bladder, get mixed up with the urine, and then they actually pee the cloudy urine sometimes called retrograde ejaculation. So sometimes you have to counsel the patient regarding these side effects, which some of them Amit has mentioned. As far as the beta 3 agonist, like we were talking about earlier, mirabegron, the only side effect maybe sometimes could be urinary retention. But other than that, there is no side effects which anticholinergics have, like somebody has a closed angle glaucoma which has not been treated. So you have to be really it's a big concern about about those patients, as well as some cognitive function that it can affect if they cross the blood-brain barrier, especially some of the molecules which could include your ditropan, oxybutynin, as well as solifenacin. These can cross the blood-brain barrier, so you have to be very careful when you're prescribing in the elderly population, which is mainly affects the short-term memory.
Yes, that's a very big thing because when you have the older patients and you have this problem with ditropan, they can cause, one of the commonest causes is the nocturia, and they take that and you give them for nocturia, and then they trip over something and break their hips. So be careful about this blood-brain barrier thing. It's becoming less and less important with the Medicare approval of Myrbetriq. Previously, we had to actually wait for trial of one anticholinergic or two anticholinergic before we can prescribe Myrbetriq, but I think it's come to the mainstream and Medicare has approved that. Gemtisa is still still requires prior authorization, but this is
If you
very,
yeah,
very
if you have to prescribe something anticholinergic in an elderly population, give trospium instead. Because it all depends which molecule crosses the blood-brain barrier can affect your brain function. So
yeah,
in case if you,
Enablex doesn't cause the blood, right?
no, and so basically the larger molecule will not cross. So trospium is considered safe for elderly population. If you also, I can tell you that sometimes you run out of these options. I usually prescribe imipramine, which is a very old and tricyclic antidepressant drug. It also has a very good anticholinergic function as well. So sometimes I usually give, if I can't give, the your typical antimuscarinic agents which could affect their brain function, because that could be some sort of a negligence. If the patient, like is mentioned, if you get a mental confusion, or a patient falls and break their hip and injure themselves. So that's why you have to be very careful in prescribing these drugs. But then you have to figure out your alternatives, and as I mentioned, trospium is one of them, or beta 3 agonist, or otherwise your very old drug, imipramine can be given also to these patients.
Great. I mean, great to have you in the panel, Ajay. I appreciate it. So I don't have any other question, and we have come to our 1.5 hours thing. Nimesh, any last comment before we wrap up?
Well, again, I really appreciate everyone's interest and the honor to really present at this forum. And I hope this was helpful. And offline would be more than happy to answer any other questions, especially as they pertain to oncology side of urology.
Great. And if anybody has any last moment questions, they can post. We'll keep the chat box open for the next 10 minutes or so. 10, 15 minutes. So anybody has any specific chat questions, please post there.
Amit, I posted the CME schedule.
Yes.
And so let people know there is another advantage. 10 CMEs. We never had this many CMEs for the AAPI convention. 2 parallel sessions, so many activities.
And we are actually trying, Tarak, just for your information, there's something which I wanted to talk to you, and now I can tell everybody also that we are also adding 2 more CMEs per day to make it five CMEs, because with yoga and meditation in the morning, which gives 2 CMEs every day. So that's also something which makes it easier for university people who require 5 CMEs a day. We're trying to do that. It's not completely done yet.
Okay, we can think about it and add some education to that yoga class.
No, they do it. We don't have to do it. It's there.
We can do women's forum also. We can make it CME too. I mean.
Yeah. But the yoga and meditation, we don't have to do the CME. They give the CME. So
they will do it themselves, separate.
They will do it. Yeah. This is art of living people. They will give the
wonderful.
CME. We don't. So,
got it.
Guys, again, thank you so much for all this year, all your support, and I just don't want to know. I want you to guys know that as far as I know, there are 4 urologists who are the past presidents. Naveen Shah, who's this year's AAPI leadership of the whole award he's getting. Naveen Shah, Subhas Desai, Ravi Jagirda, and myself, and we hope one of you guys, Nimesh, Aditya, the younger guys, come into the AAPI forum, and we need young guys like you. We've got a YPS section called Young Physician section, and we've got MSRF section, which is the Medical Student Resident Fellow section. So that is something which we encourage all of you to come and find out more about it. And what we need to do is you please register AAPIconvention.org, and we still have space, and we've got special discounts. So, by the way, Nimesh and Aditya, I hope you guys are listening to it. Tell your medical students we have got a very good offer for them: $99 for registration for the whole event. Only $99. Just to encourage medical students, and we have got same deal with the residents and fellows, and we have got a very heavily discounted for the young physicians. So please try to attend, all of you, and hope to see you there. Tarak, last words.
No, thank you. Nothing
You've
else.
done a great job, man. Come on, this is your last CME this year. I know you'll be continuing next year. So,
No,
I just
I will continue,
want you
but
guys.
it's a good learning
Yeah,
experience for me, and thank you for giving me a chance, especially our participants. Nobody asked this many questions, and so I really thank
Yeah,
participants for
it
being
has been
there,
very
showing up on Sunday. It's
it has
amazing.
been very interactive.
yeah.
I'm very impressed with over 50 people attending this, 53 exact, attending this
And,
webinar. It's
we
excellent.
usually
Amit,
get
good job.
100. We usually get 100 plus people. Father's Day actually dinged it a little bit, I'm sure, but we'll have the recording available. And if you guys want to put Nimesh, you are the president. I don't know who is the president of IAUA now. You can put it on the IAUA website. They will also like to learn this, and I will go to post. This recording is available on AAPI website, including all the other recordings are there. People who missed it, they can always listen to it.
Amit, read the last comment from Alka. She
Prostate
wants
is
to
the
give a
necessary
discount to the
evil.
medical students.
Hmm.
So I thought this is a good idea next year.
Can you give
We doctors should
$99 for
sponsor the
one
medical
patient?
students,
Yeah. I mean, I'm asking for some sponsors to cover the cost. Obviously, the cost is still $599. So we are actually taking a hit of $500 per student just to give them the. And also, I've got separate sessions for them. They have got separate research forum. They have got. They also have their DJs, so they don't have to come and listen to our ghazals or Kumar Sanu. We have got separate separate DJ. So in other words, we're going all out, and this time we have got a record attendance. We have about 170 people who medical students and young physicians have registered. 165 or 68 medical students and people who have registered. So yeah, it's going to be a good program. We're almost at capacity this year, and only about 150 slots left. People left. So if you guys want to, please visit apiconvention.org, apiconvention.org, and you'll get to know all what's happening there. Okay. So thank you so
Good
much,
job.
guys. Thank you very much.
Thank
All
you.
the best, and see you.
Yeah, by Sunday
next
you
year.
should get next Sunday you should get a CME evaluation, and please fill it out.
Okay. Great
All
job,
right, great.
guys.
Thank
Good
you,
job.
guys.
Thank you. Thank you.
Bye-bye.